Well, good afternoon, everyone. Before we start our CAPER session, we would like to spend just a moment to remember one of our board members who passed away this year, Vicki Hall. Vicki Hall is a woman who CAPER would like to celebrate her life and love as a board member and a very strong advocate. She was an amazing woman with a legacy, with a loving family. She, as a volunteer for life, which is University of Tennessee, she was her and her husband co-founded the jewelry television channel and is very well known for that, obviously. She was a great philanthropist and she was a positive person despite having a life of pain. She's a woman that had hereditary pancreatitis from a child and suffered almost her entire life, yet she was a positive person and made a huge impact on many other people's life. She had a lovely family, and we have two representatives, Christy and Macon. If you could stand up, please. And they're here to represent her. So Vicki was a professional woman at the University of Tennessee for many years in the College of Business, of Arts and Science, or excuse me, Arts and Architecture, and ended up as the Director of Development there. So she had a very important job. She traveled to Pittsburgh for medical treatment and immediately began to grasp the greater needs for education and research in pancreatic disease. She supported pancreatic research. She attended Pancreas Fest many times, and many of you will recognize her. And she also began supporting CAPER and was a CAPER board member, and her background in development was very important for the early establishment of this program. She is shown here with a couple of pictures from Pancreas Fest that she fit right in with a gang. And this last year, she finally had passed away. We look back on her life. She was a force of nature in that she was unstoppable, she was delightful, she was positive. She was strongly involved in church. She sung in the choir. She was a board member of Mission of Hope. She was involved in a Christian Academy of Knoxville. She helped with developing a tuition support. She developed a program to provide books, reading, and mentoring for underserved children in Appalachia so that they would actually have a chance to grow and develop, involved in many mission trips, and so much more. On March 30th of this year, she passed away and met her Lord and received her reward, which is a great reward. She's pain-free and in peace. Vicki's final request is that in lieu of flowers, to make donations to CAPER. So I think that we just want to probably give it applause for a great life, well-lived, and people like Vicki who's supporting the effort of each of us to make the world a better place.
I would really thank her family members, her daughter, granddaughter, Christy and Megan, for coming and being with us today. We're honored to have you. We definitely want to celebrate Vicki's life with all what she wishes. And this session is really to Vicki. Vicki believed in CAPER, believed in the mission of CAPER, which is education and spreading research and training young talents and junior investigators to really do what the field needed, because she believed we need new people and new faces and new thinking ways to advance how we care for pancreatitis. So on behalf of CAPER, I want to just run maybe less than 5 minutes through what we call the business meeting, really just to update you on some of the great excitements. Yesterday, last night, we had a wonderful board meeting and we celebrated huge milestones. So CAPER governing body consists of the executive committee, and Melina Bellin, you will hear from next, is the president-elect. Dr. Greg Cote is the immediate past president, and he's been instrumental in helping us continue the mission. Eric Golden is the chair, and he himself is a strong voice and advocate for the patients. And Christine Cataldo as the treasurer, and Mitch Ramsey, who also you will hear from in this session, is in charge of the young trainees or junior investigators committee. And before I delve more into the business, I want to thank an individual who also believes a lot in CAPER, and that's Joy Morrissey. We really would like you to come to the podium, Joy. The LP, et cetera, and CAPER have a little gift for you for all your years of service. We're not letting you go yet. Oh, that's so nice. Jill, that's why you wanted me. All right, so going quickly over the programs, we do have a program called the Pancreas Scholars. You will hear from some wonderful speakers today, and they are within the program or graduates of this program. The Scholars program is a separate, on its own entity under CAPER, where it pairs trainees who are looking for more specific mentorship into pancreatology and career development and research in pancreas, and they apply from all over. We had international applicants this year, so it's a great program for 2 years of paired mentorship. And I really want you to meet all the mentors. They're wonderful. They serve in different capacities and expertise, and they add a different perspective to the table. So you do have Melina Bellin in endocrinology, Steve Hughes is a surgeon, Dave Trondle, who's a pediatric interventional endoscopist, Dr. Papacristo as a leader in adult pancreatology as well as interventional endoscopy, Walter Park, who's a medical pancreatologist, but he also does EUS, so he does everything, and then Dr. Dheeraj Yadav in epidemiology and research in pancreatology in general. And the mentees find this enriched environment of the discussions that even the mentors have over their project very helpful. And I have the honor of watching this program since inception, since Walter really started it in his presidency, that even some of the graduates went on and got their own K award and NIH funding as a result of this program. So it's something to be proud of, and hopefully God give us the strength to continue this, because it's a lot of work, but we get the inspiration from the great fellows that we watch go through this. This is this year's program, and some of the fellows are in the first year and some are in the second year, but you will see how each mentor has at least one mentee, and some of us have two, and this really depends on the match program that goes behind the scene, depending on the interest. And I would like to personally congratulate the graduates of the last year's program, Dr. Kelly Hermans, Andrea Reiner, Irina Gorbunova, Yinan Fu, and Bradford Chang, and Somya Narayan. And please give them a round of applause. The Young Investigator Committee is a separate program, and Dr. Mitch Ramsey is in charge of it, but this just gives you a flavor of how they run workshops and webinars, and the fellows or junior investigators find this very interactive, touch bases very helpful in their own career development. And these are some of the examples of the talks that they had that the fellows give feedback if that it was helpful for their research career. Thank you, Mitch, for all your service. And we do have another program that is under CAPER, and Dr. Bellin and Venkata this year have chaired, which I invite you to tell your centers about. Physician extenders find it very, very helpful, nurses, nurse practitioners, as well as gastroenterologists, surgeons, because it does cover a wide variety of topics. These are nightly webinars that happen over 5 to 6 weeks, and it's free of charge for people to join in, and we really thank the sponsors for promoting this program too. And last, and not the least, of the very junior programs, this is a joint effort between CAPER and MPF, where it is a national fellowship, and it is where the fellows, adult and pediatrics, we choose one of each, get immersed in a pancreatology experience for 1 month. It's inspired after the Crohn's and Colitis Foundation. They do it for inflammatory bowel disease. And the institutions that host currently are UPMC and Cincinnati Children's, where the fellows spend 1 month. It's sponsored by CAPER and MPF. And the feedback from the first class that graduated last year was really great. So we hope to continue to do that. And our 2 newest fellows who joined are Tahrim Mahmoud and Susie Gonzalez from Miami. Lena?
Thank you. I get the pleasure of announcing our travel grant winners for this year's meeting. So as I think many of you know, CAPER has long been supporting young investigators and trainees to present their work here, and they get reimbursed, or they get a stipend for their travel to attend. And these are based on the top scoring abstracts. So what we're going to do is I will read the names here that you see before you. And if you're in the room, please stand up, and we'll hold all of our applause till the end and give a round of applause at the end. So Phoenix Bell, UPMC, Joseph Bajani, sorry about that, Ohio State, Zachary Hurst, Ohio State, Anmol Singh from Johns Hopkins, Sanay Sanaya from Johns Hopkins, Vibhav Gunmadi from the Hospital for Sick Children, Gaurav Surya Wanshi from University of Minnesota, Ahmad Salih from Indiana University, Chandra Rishkar Ravana from Nationwide Children's Hospital, Lillian Wang from Mayo Clinic, and Arjun Chatterjee from Cleveland Clinic. So please give a round of applause to our awardees. Very nice work. And I should add that their abstracts will be available for viewing after the conclusion of our meeting here. So please, at the end of this, go see those very interesting research abstracts. Thank you. And then I will, if I can get this slide to advance, I will turn it over, I think, to Dr. Anna Evans Phillips, who is going to announce the next award for Senior Mentor of the Year.
Good afternoon, and thank you so much for the opportunity. I am greatly honored to present this award to my mentor, Dheeraj Yadav, who's been a profound influence and a great encourager in my own career. As I do so, I wanted to give just a few words of context to this award. Dheeraj started his medical career at Jawaharlal Nehru Medical College in India, and then did an internal medicine residency followed by a gastroenterology fellowship at New York Medical College. He then followed that with a clinical pancreatology fellowship at the Mayo Clinic in Rochester, and earned a Master of Public Health degree at the University of Arkansas. He was faculty at the University of Arkansas for several years before coming to the University of Pittsburgh in 2006, at which point we've all been very fortunate that he's called this home since that time. In partnership with David Whitcomb, he worked with the North American Pancreatitis Study 2, the NAPS2 consortium, making major headway in quantifying the risks of alcohol and tobacco in pancreatic disease, along with many other significant findings of which many of us are already aware. He's now tenured professor of medicine at the University of Pittsburgh, associate chief of clinical research and academic development, co-director of the Enhancing Mentoring to Improve Research in Gastroenterology program. He is co-PI for both the consortium of the study of chronic pancreatitis, diabetes, and pancreatic cancer, as well as for the type 1 diabetes and acute pancreatitis consortium. He has funding from the Department of Defense, and also co-directs an NIH-sponsored multi-center international sham-controlled randomized trial comparing endoscopic ultrasound plus CRCP with minimally invasive endoscopic sphincterotomy versus endoscopic ultrasound plus sham. That's the SHARP trial with which many of you may be familiar. He's the author of over 200 peer-reviewed publications and has directly mentored at least a dozen individuals into academic positions across the country. I learned recently that the given name Dheeraj means patience in the Hindi language. Dheeraj is indeed someone who is blessed with a great deal of patience, but he cannot be reduced to this alone. He is many things: wise, kind, insightful, incisive, sharp, clever, creative, inspirational. I'd like to read briefly just what I had written in nomination of Dheeraj for this award. Dheeraj is a brilliant clinician scientist who personifies the ideal pancreatologist. He has worked tirelessly to advance the field of medical pancreatology, and while doing this, has facilitated numerous career opportunities for medical students, residents, fellows, junior, and senior faculty members alike. He is patient, kind, and thorough in his oversight and in his collaborations. He has created both mentored and independent academic opportunities for trainees to help them learn, grow, and contribute to the field of academic medical pancreatology through visiting fellowships, virtual education programs, research presentations at local, national, and international meetings, and grant funding opportunities. He has offered guidance and review without expectation of reward and given generously of his time and energy to follow these efforts through to completion. I've had the privilege of knowing Dheeraj since I was a medical student. He has offered unfailingly excellent and clear guidance as a mentor on abstracts, manuscripts, applications, and career decisions, not only for myself, but for numerous other individuals around me. To him, we owe our success. In addition to his activities with CAPER, he has created virtual platforms for education on pancreatology, such as PB Live, has been instrumental in the creation and maintenance of numerous collaborative networks, I already mentioned, and these are to facilitate the clinical, educational, and research communications that have advanced the field and will continue to do so. He is additionally a wise, steady, and humanistic individual whose respect for colleagues and trainees is admirable. He is deserving of this award in every way.
Thank you, Anna. This really means a lot to me. And for something that I really care about a lot. And this is something that's I'm going to cherish it for a long time. Thank you. So as I was asked to deliver my remarks today, let me see, how can I get my presentation on? As I was asked to deliver my remarks today, I reflected back on my own career. And I thought that what I can talk to the junior colleagues in the audience that could be helpful for them as they are embarking on their own academic career. And what I thought is that I could talk to them about some attributes that have helped to shape my own career, which I thought would be helpful. But before I do that, I do want to take a moment to thank CAPER for bestowing me this honor, as well as for the tremendous work as an organization that they have done over the past so many years to really fulfill an important gap in our field. And a lot of those programs that they are doing, it meant MySum actually already introduced you to many of those. And I've been fortunate to be a part of some of this. For example, over the past 5 years, I've had the opportunity to participate in the CAPER Scholar Program, and these are pictures from the 2 in-person meetings we have had for this program. And then last year, CAPER also started the CAPER Visiting Fellow Program in collaboration with NPF, and UPMC was fortunate to be asked to have an adult GI fellow come to our program, Dr. Lean Al-Said from St. Louis University, who's a trained hepatologist and a chief fellow there, who wanted to get extra training in pancreaticobiliary disease. And then to NPF for hosting the Fellows Symposium over the last so many years that has given a tremendous opportunity for fellows and junior faculty to interact with leaders in the field to develop relationships that could last a lifetime. But in terms of attributes, I do want to start with passion. And in simple terms, passion is something that, in my opinion, is something that you would want to do, not because you want a reward from that. You just do because you love doing something. And maybe one may need to ask as to how do you define yourself? And from an academic standpoint, I would define myself as a clinician to the core, a medical pancreatologist, an epidemiologist, and somebody who likes to work with others. And as you grow in your academic career, there are many things that may come naturally to you, but there are going to be many things that you are inspired by people who are around you. And I've been fortunate for each of these attributes, I've been inspired by other people. And perhaps the most important person is C.S. Picciamoni. Many of the senior members in the audience would recognize Dr. Picciamoni, who's very well respected in the field. Even before he came to the United States in the mid-60s, he had had important contributions to the understanding of tropical pancreatitis and calcifications in pancreatic disease. Consummate clinician and a teacher, and really a drive and passion for research. And my interest in medical pancreatology and research directly comes from his influence. Before I came to the United States, I had zero research experience and zero papers. But it was his influence that drove me into the field of medical pancreatology. Even in his late 80s, whenever I talk to him, he's writing something, a book or a chapter or something. And this is, me and my wife visited him and his wife last year. That's a picture of that meeting. The second person I want to talk about, and my interest in epidemiology directly stems from Al Lowenfels. Again, senior members in the audience would recognize Dr. Lowenfels, who I can say is the father of pancreas epidemiology. He's one of the most brilliant people I've had the opportunity to meet. He had this ability to take the most complex concepts and produce, in a simple way, he can explain things to you. The first time I met with him was with Dr. Picciamoni. We went together because we put together some data during my fellowship. We spent an hour with him, and he actually looked at the data. This is what the message from this analysis is. And I was just amazed from that. But then when I was doing my master's, I got an opportunity to reach out to him to seek his mentorship. And ever since, he has been there. In fact, I got an email, this is today, he's in his mid-90s, but yesterday he attended the NIDDK workshop, and he said, great job yesterday. So it's just amazing how, he has helped me over the years. And then my interest in clinical research, comes from Suresh Jari, somebody who has made important observations in clinical practice and really driven the field in so many ways. Tropical pancreatitis before he came to the United States, then cystic tumors, the field of autoimmune pancreatitis, and then diabetes as a high-risk group in patients for pancreas cancer. And then Dave Whitcomb. His energy, enthusiasm, and his dedication to research and discovery and to collaboration. And then giving me an opportunity. I don't know what's happening here, but that's okay. But for me too, after I started working with him, he basically handed me over NAPS too. And for somebody who has just finished a master's in epidemiology, it's like gold mine. What else can you ask for? And it has just been amazing that he has been there for mentorship and guidance all along. So as you think about things, the question that you may want to ask about as you are embarking on your academic journey, how would you like to define yourself, or how would you like others to define you? So think about becoming an expert in at least one area. As soon as your name comes, somebody should be able to associate you with this. This is what this person does. This is what their interest is, or this is what their expertise in. I think you'll be successful. And then you'll need mentors along the way, not one, but many mentors over the years at different stages of your life and to work with. The second thing, Anna already gave it away, what my name means, but patience and perseverance are very important. And this directly goes to my parents, who are my heroes. Both very simple people. They had their own challenges in life, but it is the way of life that I learned from them. They never sat with me to teach me anything, but they taught me by example. Whatever hardships were, never complained about things. Always wanted to do what is right and never asking for a reward for anything that they are doing for anybody. But the reason I bring it up is academic journey is very long and it needs a lot of hard work, honesty, integrity, but you need to have patience and you need to persevere about what your real interests are. And I say this, that it is important for satisfaction. It is not success. Success that is different meaning for different people. I think you need to do what you're doing because you are satisfied with what you're doing, not because you're looking for 50 papers or 100 papers or this award or that award. You need to do what you like to do. But I do believe that whatever is yours is going to come your way. But when it comes your way, you need to be humble and you need to be grounded. That's very important. Collaboration. At my own university or hospital, I've been really fortunate to work with so many collaborators. You know, in addition to David, Adam and Randy have been there all along, being supportive for the work and collaborating. Michael O'Connell, who worked very closely with me on the NAPS2 data for many years, along with Gong Tang. George, we have been partners in a lot of work over the years we have done together, and more recently, Fred Toledo and Gavin Artiel. A very important part of your research is to have great people working with you. And this is our research team during one of our team meetings. Each of these individuals are extremely dedicated and passionate about what they do. And it is their hard work that allows us to be able to do what we are doing. And I cannot thank them enough. As I mentioned earlier, NAPS2 provided a wonderful platform for me to interact with some of the brightest people around the country. Many a times I could talk to them one-to-one. I could work with them one-to-one, thinking through analyses, thinking about projects and writing manuscript, but most importantly, learning from them along the way. And in the past few years, there are a few points that I do want to make. The past 15 years have been really wonderful for clinical and translational research in pancreatitis. And one important reason for that is the support that the NIDDK and NCI has provided to the field. So that has been critical. What it has done is it has brought people with diverse interests together. And that has resulted in some important things. One, it has broken down barriers. It is not your study or my study or your project or my project. It is our project. We are all working towards complex problems where we cannot have answers ourselves. We have to work with each other. And that's important. We have to learn from each other. And that has been the biggest thing that has happened or a result of this. So thanks to NIDDK and NCI for that. But it is also interesting to see in many of these large collaborative studies for young trainees and junior faculty to be participating in this and taking ownership and leadership for so many opportunities that are coming along the way, which will help them in their careers. So that is fantastic to see. So the important point here is, it is important to remember that progress in science is incremental. We stand on the shoulders of giants. We build on the work that people who have come before us have done. and a collaborative approach is critical to answer difficult questions. Then I want to move on to mentoring, something which is very, very close to me and something that I really care about a lot. And in the past 20 years or so, I've had the opportunity to interact with some of the brightest residents, hospitalists, and fellows. And it's really, really very nice to see and satisfying to see how a resident or a fellow will start a project and then bring it to completion and then present it, and then you have a manuscript coming out of it. It just gives you tremendous satisfaction when you see this process evolves, and many a times for the fellow to go back a few years and say, look, this is something that we did together. And then you have people who really take opportunities and really run with it. So Anna has done really a wonderful job in the past few years, starting with American Pancreas Association Career Development Award to develop pilot data for QST testing, and then transform that into a career and really a program, and really led the PQST consortium in collaboration with Vikesh at Hopkins and our collaborators in Denmark, including Asbjørn Drews and Soren Elson. The program has now expanded to several centers within the US and internationally. And then to Jamie Solomon. She brings a unique expertise to our pancreas program. But one thing I want to highlight about here in Jamie, and it was discussed yesterday in the NIDDK workshop, I think it is very important for basic scientists, translational people, and clinicians to be talking the same language. If we are not going to talk the same language and we are not going to talk the same outcomes of interest, we are basically working in silos and we are never going to make progress. The thing about Jamie I see is she's equally interested to sit in our statistics meetings because she wants to know what is important for us as clinicians. Because if you know that, then you can actually bring that back to the animal models and other work that you're doing, which I think is critical. So the point that I want to make here is look at opportunities where you can mentor other people. And the thing to remember is it is not about you. Because if it becomes about you, then you cannot be a good mentor. It is not about you, it is about them. And your legacy will not be defined by how many papers you wrote. Your legacy is going to be defined by how successful your mentees have been. Important because they are going to carry the baton further. And lastly, I do want to recognize my wife, Monisha. We have been together since med school, but she's one of the brightest people that I've seen. She used to be first in class. I used to be second. No shame in that. But she's somebody who actually speaks her mind. She's somebody who will show you the mirror that you need to see. And that's very important, I think, as a person. It has been a great partnership that we have had over the years. And our two children, Rohan and Ria, are not children anymore. They are young adults and they are doing their own thing now. But the last thing I want to say here is you are on a long journey. You know, you need to have gas in the tank and you need to take care of yourself. Because if you don't do that, then it's difficult to keep going. I go to the gym, I do yoga, and I do whatever I do, but you need to think about what you need to do that is not work. At least one day a week, or maybe more. Take time off. And you need to take care of yourself and your loved ones. So I would end here, and I really want to thank CAPER for the honor that they have given me. Thank you.
All right.
the next part of the
Turn it on.
The next bit of the CAPER session will be the young investigator presentations. And different from the other sessions we've had today, we'd like to do the questions immediately following each presentation because they're all thematically very different. So to kick us off, we'd like to start with Dr. Chinenye Dike, an assistant professor in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at University of Alabama, Birmingham. She's a pediatric pancreatologist whose major research focus is on investigating the impact of gut dysbiosis on disease outcomes. Today, she'll be talking to us about acute pancreatitis is associated with gut dysbiosis in children.
Thank you so much, and thank you for inviting me. And on behalf of all the authors of this abstract, I want to thank the organizers of this program for inviting me. The title of this presentation is Acute Pancreatitis is Associated with Gut Dysbiosis in Children. I have no disclosures. I'm sorry. So we all know that we are now more aware of acute pancreatitis in children in pediatrics. And what we've heard yesterday and what we continue to hear is that children can have a very aggressive course. And they can actually progress from first AP attack to CP within 2 to 4 years, which is very rapid. The severity of the first attack can also play a role in the rapidity of progression within months. And we all know that management is still largely supported. So the NASPIG and Pancreas Committee, in an attempt to help prognosticate acute pancreatitis in children, put out a classification for acute pancreatitis in children into mild, moderately severe, and severe pancreatitis. And we used that in this study, so that's why I brought it up. We all know that previous studies of AP in children are largely single-centered and retrospective. So it becomes very difficult to predict which child would be at greater risk of developing severe AP or which child would be at risk of developing recurrent attacks besides genetic mutations. And that's why the Acute Pancreatitis Registry was born in Cincinnati Children's Hospital. And it was to enroll children with their first AP attack, collect clinical outcome data and biomarkers, but also follow these children longitudinally over time and see how many of them progress to recurrence and also collect biomarkers that follow up. But they also collected patient-reported outcomes. We all always thought that the pancreas was a sterile organ, but we now know that's not true. And what happens in the gut, especially the lower GI tract, affects what happens in the pancreas. So when the gut microbiome secretes the antimicrobial peptides in the pancreas that can help check inflammation within the pancreas. Inversely, when the antimicrobial peptide production in the pancreas is low, you can have overgrowth of bacteria in the lower GI tract. So there's a bidirectional relationship between the two. Adult studies have shown us that acute pancreatitis is associated with gut dysbiosis and that this is linked to severity. We all know that the etiologies of acute pancreatitis in adults can be different from children, so we can't really extrapolate. We don't know what happens in children. Excuse me, it's a bit fast. So we don't know if acute pancreatitis is associated with microbial dysbiosis in children and if the severity is associated with dysbiosis in children as well. And that's why we came up with our objectives and hypotheses. The first one was to characterize this to taxonomic and functional profiles, comparing them between children with their first AP attack and healthy controls. We hypothesized that gut dysbiosis impacts children with AP when compared to healthy controls. We also wanted to determine if AP severity affects these profiles. And we hypothesized that gut dysbiosis is associated with a severe AP course in children. So this was an IRB-approved observational prospective cohort study enrolling children less than 21 years old, children and young adults less than 21 years old, within their first AP attack aimed to collect 2 samples within the first week of the first AP attack, and then compared this gut microbial signatures with healthy controls, historical healthy controls from the GI clinic from the same location. And so what the methods were, the stool was collected within the first AP attack, frozen, then DNA extraction was done, a sequence library construction was done, and then shotgun metagenomics was done. And then we looked at the stool taxonomic and functional profiles using the biobakery tool. This demographic table just shows that the AP cohort and the healthy controls are similar in a lot of demographics, age, sex, race, or ethnicity. And most of the cohort were mild AP compared to severe AP. And this figure shows a hierarchical heat map clustering with the AP cohort on the right and the healthy control on the left of the figure. We can see, looking at the very dull colors, less abundant species, and then the very bright or hotter colors are more abundant species. We can see that in the healthy controls, you have species abundance when compared to the AP cohort. Additionally, this box plot looks at with median in the middle and then the box plots interquartile ranges. We can see that the richness of species within samples was significantly higher in the healthy controls compared to the AP cohort. We also see the same thing in the beta diversity. So this is the principal component analysis, and you can see that there is distinct clustering of species between the healthy controls and the AP cohort. This was also seen when you look at the mild AP compared to the moderately severe and severe AP group. So this figure on the left looks at species that are relatively the species differential abundance between the mild and the severe AP groups. On the left of this figure are species that are underexpressed, and on the right are species that are overexpressed. I'm so sorry. And you can see when you zoom in on the figure on the right that 2 species that are overly expressed in the severe AP group are Enterococcus faecalis and Clostridium citrinae. So this, in conclusion, this is the first study to look at AP and gut dysbiosis in children. Just like in adult studies, pediatric AP is associated with dysbiosis. And Enterococcus faecalis and Clostridium citrinae are 2 species that stand out that could be markers of severity. It's possible that manipulating the gut microbiome, especially within the first 24 to 48 hours, may mitigate severity, but also may help reduce recurrence. So what does the future hold? It's bright, I think. We need to confirm these pilot studies in a larger multi-center study. We also need to correlate this taxonomic and functional profiles we're seeing in the microbiota with serum cytokines that have been already implicated in acute pancreatitis in children. But I think the next big step would be to target interventions to help mitigate severity and recurrence. With that, I would like to thank all the members of the Pancreas Care Center at Cincinnati Children's Hospital and the funders of Dr. Abu El-Hajja for this study, and also for Dr. Abu El-Hajja for her excellent mentorship. Thank you.
Right, and with that, we'd like to open the floor for a couple of questions. And if there, we'll take them now. And if there are no questions from the audience, I'll start with one from the get-go. It was very interesting data, and thanks so much for the heat map. I think that one picture tells 1,000 stories. One thing that was so interesting was there almost seemed to be 2 populations within the acute pancreatitis. Half of them had almost, I mean, it was almost a sea of blue, and the other half had a little more diversity. Were you able to look at antibiotic exposure during the index hospitalization? Could that explain that difference?
That's an excellent question. So many of the patients were not on antibiotics, but we had about 2 patients in the AP cohort that were put on antibiotics, I think within the first 48 hours of hospitalization, but others weren't on antibiotics. So that's an excellent question and point.
Dr. Sahantal?
Yeah, just to do a little mentoring here. So isn't this naive to think that changing microbiome going to affect severity and recurrence? I mean, to me, it seems it's a simple association. I mean, you can get these changes with many other diseases, and maybe even after a good meal. But I don't know if I would go down this road, because we had a great presentation at the EPC about microbiome, and basically the bottom line was that it's massively overhyped. A lot of effort goes into it, and there's not much to show for it so far.
No, I think that's an excellent point. I was at the EPC as well, and I spoke to the lady who spoke on the microbiome. I think we need to, this is a small pilot study, so I think it's going to be very difficult to extrapolate at this time. But if we do confirm it with large numbers and try to target particular species that may be seen in the severe group, it could help. Thank you, though, for the point.
I also want to make a comment on that, if I may defend our work a little bit. So I think I'm a strong believer now that it is the time that clinician scientists and translational scientists have to work with the wet lab on a big scale. And that's actually also what Shania and I are doing. So some of this is what is the chicken and the egg? And we talked about it yesterday. Do you see dysbiosis because the severity is what drove the dysbiosis? And does dysbiosis really happen within a day? We don't know. Because these patients, we didn't have their baseline microbiome. So what you could do in the lab, you could bring animal models before you induce pancreatitis, study their microbiome, induce pancreatitis at different severities, study their microbiome, but also see if some of that signals and pathways could be investigated further. And this work is being actively worked on.
Thank you. Thank you.
Right. Our next speaker is Dr. Kelly Harrimans. She's a general surgery resident at the University of Florida and is an aspiring surgical oncologist with a keen interest in cancer health disparities in the pancreatic microbiome. Her work spans various aspects of cancer treatment, ranging from improving clinical trial enrollment to exploring the role of the oral microbiome in cancer-related cachexia. Today, she'll be speaking to us about the inflammatory phenotype of pancreatic ductal adenocarcinoma.
Thank you so much, and really thank you for the honor of presenting today. Today, I have the privilege of talking about the inflammatory phenotype in pancreatic ductal adenocarcinoma. I have no disclosures. So as a part of my talk today, I'm going to talk about the background of pancreatic cancer, some of which you all know, methods, results, and then our next steps. So as many of you all know, pancreatic cancer is a particularly deadly disease with an estimated 5-year survival rate that has now just increased to 12%. Unlike other cancer types, immunotherapy has shown little success. And this is in part due to its immunosuppressive tumor microenvironment. So the trickiest part of pancreatic cancer is that not all of our patients are the same. It's a particularly heterogeneous disease, and we've really tried to characterize these patients using multi-omic technologies and have attempted to apply precision medicine to pancreatic cancer. Recently, there's been several groups that have proposed transcriptomic subtypes. However, the translation to clinical utility has been tricky because of expense and actually doing it in a clinical setting, which has spurred further investigation into proteomic subtyping of these patients. Go back. This is some of the work from our lab, from Dan DeLeo, who is here today. looking at the tumor microenvironment and the inflammatory proteins and how they're related to neoadjuvant therapy and can correlate with patients' overall survival. So as part of this work, we really wanted to see how is the inflammatory, can pancreatic cancer really be categorized based on its inflammatory milieu? And how can we use that to apply to precision medicine? So we collected 59 pancreatic cancer specimens into our tissue bank. And I want to clarify that all of these patients were naive to any treatment. So they didn't get any radiation or chemotherapy prior to their resections. And they went straight from the operating room into our tissue bank in the -80. We then homogenized all of these samples, probed them for 41 inflammatory proteins using the Luminex multiplex assay. And then our statistical analysis, we used the T-distributed stochastic neighbor embedding, which really groups like proteins with like proteins and dissimilar proteins with dissimilar proteins. We then compared the groups using different methods, the Mann-Whitney, Fisher's exact, and then looked at survival. And statistical significance was determined using the Bonferroni correction at 0.0015. So what we found when we looked at the inflammatory proteins of all these patients is that two distinct subgroups arose when we used the TSNE analysis. So group one, based on the proteins, we deemed the immunomodulating, and group two, the immunostimulating. And so group one and group two will be changed to that throughout this talk. What we found was that there were 10 inflammatory proteins that were significantly different between the two groups. And I want to point out that IL-1RA was the protein that really differentiated the patients in the two groups. So high levels of IL-1RA that's how you could completely choose which patients went in which group. When we looked at the characteristics of patients between the two groups, we found no differences in demographics, pathology. But when we looked at their blood loss, we found that this is what came out of all of our comparisons as statistically significant. So to dive into that a little bit deeper, we omitted patients with tail tumors. And we did this because we've seen in our prior work, which Dr. Reiner will present next, that there are differences biologically in pancreatic head and tail tumors. And if we're looking at blood loss, there are certainly operative differences between head and tail resections. We reran the TSNE and then we found that our results were the same. When we looked at just pancreatic head tumors and reran the TSNE, we actually found that diabetes status was different between the two groups. Additionally, we found even more difference in blood loss between our two groups. To further dive into what was causing these inflammatory proteins, we looked at the CD3 positive, CD8 positive, and SMA positive cells using a tissue microarray and IHC staining. And we quantified these and we found no differences in this small cohort. When looking at the survival of these patients, we found that the immunostimulating tumors they trended toward a longer median survival by 9.2 months. And even though this isn't statistically significant, clinically, it is quite clinically significant for a lot of our patients. So to conclude our research, these immunomodulating PDAC tumors were less likely to be diabetic. They were more likely to have intraoperative blood loss, and they trended toward lower postoperative survival. And then the immunostimulating PDAC tumors were more likely to be diabetic, less likely to have increased operative blood loss, and trended toward longer postoperative survival. So we wanted to look in kind of the two different aspects. So, we found these differences in blood loss and diabetes. So to dig a little bit deeper into the blood loss piece of this, we looked at it as kind of a dose response. So looking at the cutoff between 500 mLs and a liter blood loss in the operating room. And we found that both of these continued to be significantly different between the two groups. We found differences in estimated blood loss, but what I found particularly interesting was that in the immunomodulating group, this was the group that actually received a blood transfusion intraoperatively. But there was no difference in crystalloid or colloid administration. In these patients, the immunomodulating group were more likely to have an open operation, but they didn't all start that way. So these patients actually started with a laparoscopic surgery, and then because of blood loss or for some reason, they were converted to an open operation. So immunomodulating PDAC tumors were more likely to have increased operative blood loss, more likely to have a blood transfusion, and were more likely to have an open operation. And to emphasize, they were more likely to convert to an open operation. So future directions, as far as the blood loss piece, we really want to look into how blood transfusion impacts the peripheral immunophenotype, how blood transfusion affects circulating tumor cells, and then looking at blood transfusion versus autotransfusion. Again, kind of the chicken and is it the chicken or the egg? Is it the blood transfusions are causing this change in the immunophenotype, or is it the immunophenotype of the tumor that's causing these patients to have more blood loss and require more transfusion? We've then also looked at the diabetes portion of this, and we compared the non-diabetic tumors with the patient tumors from patients who had developed diabetes. And we found that these FGF2, MCP3, TNF beta, and IL-1RA, again, were statistically different between the two groups. And I gave this its own slide. I wanted to emphasize that we looked at all of the diabetic patients that we had this data for. So we also had a benign group. And what we found was that the IL-1RA levels in the patients with cancer were significantly higher than those with benign disease. So these are all of the diabetic patients with samples. So moving forward, we really need to expand our samples always. And then do a deeper dive into the pathology. Is this new onset diabetes, or is this existing diabetes in PDAC? And we're going to be looking at the tumor biology versus whether or not it's just destruction of islet cells. To conclude, I just want to briefly talk about IL-1RA that comes up throughout this talk. It's the receptor antagonist of IL-1 alpha and IL-1 beta at the IL-1 receptor. And this was our protein that distinguished our two subgroups. And though IL-1RA itself is immunosuppressive, it actually increases as a response to inflammation and infection. And this protein increases tenfold higher when compared to IL-1 alpha and IL-1 beta. It's currently under investigation for its role in PDAC diagnosis and treatment. In preclinical models, it's shown to reduce tumor proliferation, migration, and invasion. And actually in colon cancer, it's been associated with chemosensitivity and may potentially be used as a biomarker in pancreatic cancer. So I also just wanted to briefly talk about CAPER in general. When I started 2 years ago in CAPER, I was not sure which direction this project would go. So we put together this timeline, and really throughout, we have gotten most of it done. The next generation sequencing, Dr. Hughes, I promise, will eventually get done. And we're going to compare that to the other subgroups. The statistical analysis, demographic associations, and then, of course, applying it to precision medicine is next. I truly want to thank all of you for the opportunity to present today. It really is a profound privilege. I want to thank Dr. Hughes and Dr. Trevino, who are in the room today, Dr. Yadav for being a fantastic mentor as part of the CAPER Scholars Program, and then the Paradigm Program, who I am funded with for my research. I'd be happy to take any questions.
Looks like we have several questions from the audience. We'll start over here.
That's a great study. Did you correct for jaundice? Because patients with a stent might have inflammation, which might predispose to one of those particular immunophenotypes.
We saw no difference in patients that had stents between the two groups. I should have added that data, but we did collect that data and look at that a little bit more. What I would actually like to do in the future is look at the type of stent that is used in the patients. I anticipate it's probably the same across the board, given our institution, but that'll need more research. Yes.
So it's quite interesting to see you have different types of inflammation in two groups of tumors. Kind of a long-standing, tried and true approach is the Glasgow prognostic score that just measures the ratio between the CRP level and the serum albumin level. And if you have low albumin and high CRP, that is a much worse prognosis, and it reflects an inflammatory process blocking normal protein synthesis. And I'm wondering if you've looked at that and whether or not it correlates with what you have, and you've found a more sophisticated way of confirming a standard approach.
We haven't looked at that per se. We have tried to collect CRP on all of our preoperative patients. All of these patients were in our tissue bank already, so not everyone that went to surgery had an existing CRP because they were often referred from outside institutions. But moving forward, we've done a really good job of looking at nutrition markers as well as markers of inflammation. So also getting like a CBC with a diff instead of just our classic labs that we had ordered preoperatively. But yeah, I think that will certainly be a great next step to look at. Yes.
Just let me know the mark you look at is the parallel one.
Yes.
We did I see and the QP cell really operating your point was marked.
Oh, that's great. Thank you. We'll have to talk about that. I really appreciate it.
It's one of the very top.
Yeah, it seems to come up no matter what we start to look at. I think that IL-1RA likely has more of a story to tell that I think we'll find out in the coming years.
A quick question. Excellent work, and CAPER is so proud of you for doing an amazing job and making us all proud. Do you, for me as a physician who doesn't deal with cancer as much as the adult world, is that something that is making physiologic sense, what you found? And are you aware of IL-1 inhibitors being used in some of similar cancer types? And if so, like anakinra, at what stage?
So yes, to all of the above. It does make sense physiologically, kind of on a number of levels of what we're finding. There was recently a study that was published in Lancet that looks at circulating plasma proteins and the risk of patients with diabetes, type 3C diabetes. And what they found was IL-1RA in the plasma was actually associated with pancreatic cancer versus benign disease. So I think that we'll have to find out where the IL-1RA is coming from in that sense. Is it from the pancreas, or is it from the immune response from the macrophages? So, and then as far as the blood loss piece, it's interesting because IL-1 alpha is associated with thrombin in the coagulation cascade. So the levels that are increased in our group make sense that they would have less blood loss.
Great, thank you.
Yeah, of course.
All right, our next speaker is Dr. Andrea Reiner. She's a chief general surgery resident at the University of Florida. As a passionate advocate for surgical oncology, Dr. Reiner's clinical and research interests revolve around pancreatic cancer. She's deeply committed to addressing cancer health disparities, exploring translational genomics, fostering diversity in surgery, and contributing to global surgery initiatives. Today, she'll be talking to us about leptin expression in cachexia in pancreatic ductal adenocarcinoma.
Thank you so much for that introduction, and thank you for the honor of presenting today. I have nothing to disclose. So in this talk, I will begin with some background research on cachexia and PDAC tumor location, which provides some rationale for studying leptin. And then we'll go into some detail on the differences in expression of leptin between PDAC and normal pancreas. So cancer cachexia is seen in over 80% of patients with PDAC. And cachexia is driven by the tumor's effect on the body, as well as host cytokines, systemic inflammation, reduced calorie intake secondary to anorexia, and increased metabolism. Cachexia still, though, remains poorly understood, and there are no effective therapies on the market today. This devastating syndrome really reduces patients' quality of life. It reduces their ability to tolerate chemotherapy, their surgical candidacy, and culminates in shorter survival. However, my thought was that these statistics related to cachexia may oversimplify reality with PDAC. As further rationale for studying PDAC-associated cachexia by tumor location, and without going into too much detail on this slide, we all know that the pancreas has embryologic, anatomic, and physiologic diversity, and there are oncologic differences seen in the natural course of disease, oncogenic mutations, and metastatic propensity based on the tumor location. So we hypothesized that the anatomic location of the primary tumor would influence cachexia. We conducted a retrospective review of treatment-naive patients who underwent a pancreatectomy over a 9-year period. And as the minority of patients who undergo pancreatectomy have distal tumors, we identified these patients first and then matched them to patients with tumors in the head of the pancreas based on age, sex, and NT stage. Our primary outcome was presence of cachexia, which we defined as 5% or more body weight loss in the 6 months preceding their diagnosis. We collected clinical, serologic, and anthropometric data from the time of diagnosis, and we obtained CT images and analyzed those using slice-o-matic software to measure skeletal muscle and adipose tissue. And then we also performed RNA-seq analysis on available archived tumors. So just to take a quick step back, there are several definitions that could be used for cachexia, but one of the more widely accepted and simplistic definitions is 5% body weight loss or more in the 6 months preceding diagnosis without starvation. So this is what we used for our study. And then in 2013, Martin and colleagues published this paper in JCO looking at cancer-associated cachexia and quantification of skeletal muscle in relation to survival. They identified body weight loss of 8% or more to be significantly associated with reduced survival. And they also measured skeletal muscle index and muscle radiation attenuation, which characterizes the muscle quantity and quality respectively. They defined thresholds for men and women, as well as based on BMI categories. So skeletal muscle and adipose tissue can be characterized using slice-o-matic software, and a commonly utilized image is the axial view of the L3 vertebral body level. And we basically can color in skeletal muscle, visceral, and subcutaneous adipose tissue, and the software will quantify the associated mass. So here are 2 representative images from our patients, and you can see that the patient on the left has higher skeletal muscle mass, and it's also a greater quality denoted in the red, whereas the patient on the right has less skeletal muscle that's of poorer quality, shaded in with pink and purple. And then you can see that the patient on the left also has less subcutaneous adipose tissue. So in our study, we had matched 24 patients with distal tumors to 24 patients with pancreatic head tumors. And we found that there was a trend toward a higher rate of cachexia among patients with pancreatic head tumors, but there was a significantly higher % body weight loss with patients with pancreatic head tumors. BMI, skeletal muscle index, muscle radiation attenuation, and adipose tissue values were similar between the two groups. And then we created a composite score denoting how many of those previous criteria, how many of those thresholds were actually met. And we found that patients with tumors in the head of their pancreas tended to meet more criteria than patients with tumors in the tail of their pancreas. Additionally, albumin was significantly lower among patients with pancreatic head tumors, and bilirubin was higher, as would be expected with patients who present with obstructive jaundice. And there was a trend toward lower hemoglobin with pancreatic head tumors, which is consistent with cachexia and its association with anemia. Kaplan-Meier survival analysis revealed significant differences in survival between our two groups. And then we identified archived tumors from these patients and performed RNA-seq analysis. So tumors from cachectic patients, of which we had 6 tumors, regardless of where the tumor was located, were compared to patients who were not cachectic. And we had 9 tumors from patients who were not cachectic. And we performed this analysis to identify enriched pathways that were associated with cachexia. So this figure is a sampling of some of the most significantly enriched pathways, and we identified multiple pathways that were involved with adipose tissue, skeletal and cardiac muscle, as well as metabolic processes. And one of the pathways that caught our attention was white adipose tissue browning, which is a hallmark feature of cachexia that precedes skeletal muscle atrophy and contributes to high energy expenditure. And within this pathway, the leptin gene caught my attention. This was differentially expressed with a 5.4 times higher expression in tumors of cachectic patients compared to non-cachectic patients' tumors. So from this particular study, what we concluded is that PDAC-associated cachexia is a rather heterogeneous syndrome that can be influenced by the primary tumor location. That resectable PDAC is associated with, or pancreatic head PDAC is associated with higher prevalence of cachexia and more features linked with poor prognosis. Pancreaticobiliary obstruction and hypoalbuminemia in patients with pancreatic head tumors may suggest compounding effects of nutrient malabsorption, possibly contributing to shorter survival. And while nutritional prehabilitation may benefit select patients, molecular analysis via biopsy may provide an opportunity for a precision medicine approach in which we could identify a subset of patients whose tumors have drivers of cachexia for which nutritional prehabilitation may not actually be of much benefit. I think further from this study, what I take away is that in future studies, my plan would be to control or adjust for the tumor location because of the heterogeneity of this syndrome. So based on the findings of this study and identifying the leptin gene as being enriched in patients with cachexia, I wanted to dive further into leptin expression in PDAC tumors. So just to review, leptin is an adipokine that functions to decrease appetite, and it's primarily produced in adipose tissue. If the axis is functioning properly, patients who have higher adipose tissue should have higher levels of leptin, which then exerts its effect on the hypothalamus to suppress appetite, thus preventing further weight gain. However, leptin dysregulation may play a role in cachexia anorexia syndrome. So leptin is not really produced in the pancreas in significant quantity, but perhaps aberrant leptin expression in the tumor itself could contribute to a cachectic phenotype independent of a patient's adiposity. And higher levels of leptin have also been associated with chemoresistance, so it could potentially impact both disease progression and cachexia. So we hypothesized that aberrant leptin expression in PDAC tumors is associated with a cachectic phenotype, and we wanted to investigate this further with a larger sample size. So we went back to our tissue bank and identified patients who underwent pancreatectomy and had tumor or benign pancreas archived. And the benign pancreas would serve as our control group. We identified 31 patients with PDAC, some of whom were also cachectic, and 9 patients who underwent pancreatectomy for benign pathologies to serve as our controls. We extracted RNA from these specimens and performed PCR to quantify both the leptin gene and its receptor expression. So between our two cohorts, as expected, there was a significant difference in the age distribution with the control patients being younger. This is relevant as there's an inverse relationship between age and leptin levels. Leptin expression also tended to be higher among the cancer patients compared to controls, but there was no difference seen in the leptin receptor. We then assessed correlation between leptin expression and several variables. So in our cohort, we found that increasing age did not actually correlate with leptin expression. We did find, though, that lower BMI correlated significantly with higher leptin expression. And then we had hypothesized that leptin would be associated with increased weight loss, possibly along a spectrum, yet our data suggests that there was an inverse relationship. So when we performed a regression analysis adjusting for age, sex, and BMI, all of which influence or can influence leptin levels, we found that cancer patients had higher levels of leptin expression compared to control patients with a significant p-value. So based on these preliminary studies, leptin expression may differ between PDAC and benign pancreas, but the relationship between tumor expression and cachexia remains unclear. It's unclear how tumor leptin expression and systemic leptin levels may correlate, if at all, but systemic levels likely have a much greater influence on the cachectic phenotype. Lastly, the role of inflammation was not assessed in this study, but undoubtedly has a significant impact on cachexia. So while I found this project to be incredibly interesting, I think that it really raises more questions and more ideas for future investigation. The complexity of all of this, may be why we have yet to make significant strides in combating cancer cachexia. So I would like to recognize some folks who have been instrumental in my professional development and this work, in particular, Dr. Yadav, Dr. Hughes, and Dr. Trevino, as well as other members within their respective labs, especially Song Han and Garrick Tushosky Aliman. I'd also like to again thank CAPER for the opportunity to be involved in this wonderful program. And I thank you for your attention and would be happy to take any comments, questions, criticisms.
All right, while we're looking for questions from the audience, I'll ask the first one. One of the differences between a pancreas head tumor and a pancreas tail tumor might be the incidence of exocrine pancreatic insufficiency. Was there any way to assess for that in the database that you were using for this project?
Yeah, unfortunately, there was not. A lot of these patients, as Dr. Harrimans had mentioned, are referred from outside providers. And, we have enough data to basically take them to the operating room and don't necessarily dive deeper into some of these additional labs that would be of great value. So a great point, but unfortunately, we don't have any data for that.
Hi, Phil Greer, Aerial Precision Medicine. Do you have any idea of whether those were germline or somatic mutations that were causing the leptin transcription increases in any of your tumors, or anything? Have you looked at any of that yet?
Yeah, that's another great question. Some of our patients who are enrolled in our tissue bank, we do have normal pancreas to compare and specifically look for somatic mutations. But for this particular analysis, we don't have that sort of discrimination.
All right. Thank you.
Thank you very much.
And our last speaker of the session is Dr. Yehua Zhang. She is the medical director of Children's Hospital of Los Angeles Pancreas Program, as well as the director of their international education program. She focuses on taking care of patients with acute recurrent pancreatitis or chronic pancreatitis, along with other pancreas disorders, and also she is a specialist in inflammatory bowel disease. And today she'll be speaking to us about the comparison of current assessment tools for children with pancreatic exocrine insufficiency.
Okay, thank you. Thank you for the introduction. And also want to thank the CAPER program to give us opportunity to present this afternoon. I'm actually presenting on behalf of Dr. Yinan Fu, who is a fellow I mentored through his fellowship, and he just graduated and started his new faculty position just this month. So he couldn't be here with us this afternoon. So I'm going to present on his behalf for our work through the CAPER program. So we will present the, we want to present the comparison of a current assessment tool for children with exocrine pancreatic insufficiency. So you're already all very familiar. The EPI can happen in a good variety of pancreas disorders. It can lead to the poor digestion and food digestion, chronic diarrhea, severe malnutrition, and also complications that they may have a poor quality of life. So the current assigned modalities for EPI, including direct test and also indirect test. So for the direct test, including secretin, enhanced MRCP, the drilling tube method, and also endoscopic pancreatic function test. So for the drilling tube method, is uncomfortable and also it's cumbersome, so it limits its clinical use. We don't really use that in pediatric ward. And secretin enhanced MRCP is not validated in children yet. And endoscopic function test, and on the other hand, is considered more accurate and probably important for early detection of EPI. For the indirect test, includes 72 hours of a fecal fat test. We don't widely use that because time consuming, and also it's not pleasant for individual to handle the samples. And fecal elastase, it's well known, it's a wide, commonly used screening tool for the EPI, but its value can be affected by stool consistency and is more indicating for more severe EPI. And CARB-13 makes a triglyceride breath test. It's not really available in US. So our project want to aim for endoscopic pancreatic function test, EPFT, and compare this one with the other available PFTs in our study. So EPFT was found to be comparable to the drilling tube test, and it's more sensitive to fecal elastase, and it can be safely performed in children. So it's a single center study. We collect this patients' data from at the CHLA. So they underwent the EPFT from 2018 to 23. So we do the EPFT. So endoscopy, we inject with secretin at a 0.2 microgram per kilo with the maximum dose at a 16 microgram. And then at 5, 10, 15 minutes after injection, we collect the samples, we check pancreatic enzyme activities, including amylase, lipase, trypsin, and also chymotrypsin. And at the 30 minutes, 45 minutes, and we measure the bicarb concentration. So this is a modified protocol with more data collected from EPFT. And we actually did continuous suction. So we also recorded all the secretion volume from duodenum, so we know how much pancreatic juice is secreted. For patients who underwent secretin MRCP, we did measure the pancreas AP diameter and also calculated pancreas parenchyma volume 3D through the 3D sequences. And we also analyze the T1 signal for pancreas against the spleen and also muscle. And then apparently we look at the structures, abnormalities for chronic change. And we also collected data for pre and post secretin injection of duodenum volume change from MRCP, as well as the small intestine volume change. We also collected clinical data of patients' clinical symptoms and also laboratory tests, including the abdominal pain, bloating, the stool consistency, steatorrhea, and weight loss or malnutrition. The laboratory tests, just including the fat-soluble vitamins and amylase lipase, lipid profile, and hemoglobin A1C, and also fecal elastase. And for patients who underwent EOS, we use Rosen criteria just to look for minor and major chronic changes. So the results. We have a total of 53 patients who had the EPFT during the period. Among those patients, 57% they were female, and the median age was 14. The age range was 4 to 21 years of age. So the primary indication for EPFT at our center is acute recurrent pancreatitis or chronic pancreatitis. And I know people will ask, so acute recurrent pancreatitis is not the indication for EPFT, but for patients with very frequent attacks and you are highly suspect the patient already progressed to chronic pancreatitis. However, they don't meet criteria, diagnostic criteria from their image showing this chronic change. So we also offer this EPFT. And other patients, they may have pancreas atrophy, or they have poor weight gain and or malnutrition. From screening, they have a low stool elastase. We perform EPFT. So this is the EPFT, the enzyme, the overall looking, and so we just the data presented here is not really just showing to diagnose EPI or not with the cutoff. So we use a laboratory cutoff is really just separating normal and also abnormal the trypsin, chymotrypsin, amylase, and lipase, and we can see they're not parallel. So around 40% of patients, they have a low amylase, and 30% patient, they had the low lipase, and versus the trypsin, the chymotrypsin is only about 20% of patient, they show this low enzyme activity. But regardless, this all four enzymes, we can see they show the similar trends. At 5 minutes, they have highest enzyme activity, and over time at 10 and also 15 minutes, you can see enzyme activities just decrease over time. And it's also for bicarb at 30 minutes, the concentration was much higher, and at the 45 minutes, the concentration just dropped. We don't have any other, we don't really know the peak of bicarb. We are actually collecting the 20 minutes data right now, but we don't have a lot of subjects or data, so did not present it here. And so next we look at the enzyme activities versus pancreatic fluid secretion. And we can see for this, the red lines, and there are samples with, there are patients with normal pancreatic enzyme activities. And for these yellow ones, they have low enzyme activities. And you can see for all four enzymes, if they have a normal enzyme activities, they do have a significant higher pancreatic fluid secretion. And same thing for bicarb. If you have a bicarb, normal bicarb concentration, you do tend to have a higher pancreatic fluid secretion as well. And we look this enzyme against MRCP pancreas size. So that including the AP diameter as well as pancreas parenchyma volume we calculated. We also showed a similar trend with the normal pancreatic enzyme. They tend to have a bigger pancreas size. And this is another one. We compare pancreatic fluid secretion, you either from EPFT, the suction, the actual volume, and versus the secreting enhanced MRCP. And actually you can see pretty good correlation between the two. So the upper figure, you see there's a blue line. That one is the duodenum volume secretion. And the x-axis is a secretion from EPFT collected, it's actual volume. And then the y-axis is the volume calculated from MRCP. And if you look at the duodenum, it's almost 1-to-1. And the right line is the small intestine volume, which is higher in the volume, but it's also correlates well. We also compared the enzyme levels against chronic features reported on MRCP or EOS, and we don't really see significant correlation between the two. And for clinical symptoms, patients with steatorrhea, they tend to have a lower lipase, which is not surprising. And then they also correlates with the trypsin and also lower bicarb as well. And for malnutrition, it's more likely associated with the low lipase and other clinical symptoms, including the pain and stool consistencies. They were not correlated with the EPFT pancreatic enzyme. And for the fecal elastase, and we also see the trends in normal, with the normal pancreatic enzyme, they tend to have a higher fecal elastase. And then so you see the correlation is also pretty good as well. And for other blood tests, we don't really see significant correlation with the pancreatic enzyme. So in conclusion, the children with low pancreatic enzyme activities correlates with a smaller pancreas size and also lower pancreatic fluid secretion, and the volume calculated from secreting enhanced MRCP was parallel to the actual volume collected on EPFT, and the steatorrhea was associated with a low lipase, trypsin, and also bicarb. Malnutrition more likely associated with the low lipase, and we don't see other symptoms or laboratory associations with the pancreatic enzymes. So I want to thank Dr. Abuel Haja, and she helped mentor this project through CAPER, and Dr. Nguyen is the radiologist from CHLA, and Dr. Andrew Child helped us with the image guidance, and Dr. Travis Pieser just performed the EOS. So I will stop here and happy to take comments and then questions. Thank you.
Hi, Darwin Conwell, University of Kentucky. Thank you for that presentation. A couple comments, really. One is I have a question about when you did your EPFT in relation to when they had pancreatitis in the recurrent acute pancreatitis patients and also the chronic pancreatitis patients, because what has been reported by Dr. Dreiling years ago with the Dreiling tube is that the pancreas can be stunned.
Put the microphone a little closer, sorry.
I want to know when you did your EPFT after their acute bout of pancreatitis or even acute bout of pancreatitis during the chronic pancreatitis patients, because what's been shown by Dr. Dreiling is that the pancreas can be stunned after acute pancreatitis, and doing a pancreas function test at that time, you can get inaccurate results. So that's something just to look at your data. It's not a criticism, just look at your data and see how long did you wait after the recurrent attack, because that can give you some false positive test. The other comment I would make is, and this is for my son, did you use the cutoffs that Orlando is using? Okay, great, because just people know that there is a test that's already been CLIA certified at Orlando, where most of us are sending samples, the pediatricians are, so that's good. Thank you.
Yeah, thank you.
I would say this volume, it's not going to be very accurate with suction of the scope. So I think you had a correlation, but the volumes don't really help you a lot. And what Dr. Tosca showed is that a bicarb value is when you try to look at, when you try to quantitate the volumes, you don't really need the volume. You're just sampling how much is being secreted from the pancreas at that time. I think your data is consistent with when you give secretin, you're stimulating pancreatic duct cells. And so when you see the high enzyme output, then it drops, is all you're doing is just flushing out what's in the duct itself. So you'd expect over time that the enzyme concentrations would go down because you're not really stimulating the acinar cells. But good work.
Okay, thank you. So for the EPFT test we perform, and then it's absolutely right. We try to avoid now the perform EPFT during acute pancreatitis episode, because we know it any EPI assessment, if it's done during the acute episode, you can affecting the volume, enzyme, and also fecal elasticity and everything. So for all the EPFT we perform, and patient is all at the normal baseline, and this is an elective outpatient procedure, so everything was done at a baseline. And as for the cutoff, and for this one, we just use the group, the cutoff for like a normal, and it's easier to present the data and just distinguish the two with normal and abnormal. It's not trying to, as I mentioned, it's continuous, because it's continuous variable. We also did analysis and try to see the continuous variable and against in the modalities we just try to look at, and they're like a comparable. So this one is rather not distinguish EPI and then or now EPI. It's more like upper and like normal and also abnormal like groups, and it's just easier to present the data. And in the actual world to diagnose EPIs, and then we don't really have age specific children and normal range for EPFT like enzyme activity. I think that's the part like data we need to work on, and we need to collect for pediatric EPFT. And we use in clinical work, when we do use diagnose for EPIs, it's like put multiple factors together. I also look at my some papers and for that EPI, but that one cannot be used as the normal range yet. So we simply don't have a age specific normal range for kids.
Thank you. I think one more question from Dr. Hughes.
Steve Hughes from Florida. You kind of answered my first question, is wouldn't it really be nice if you could have healthy controls as part of your sample set? I suppose that's probably not ethical, but perhaps children that have endoscopy for other reasons with no evidence of pancreatic tissue. The other controls I was hoping to maybe have is if you could give us some insight into these children's fecal fat, which is kind of the final ultimate thing, or perhaps even a biopsy of their brush border with some assessment of compensatory mechanisms within the brush border enzymes that might overcome pancreatic exocrine insufficiency. But a ton of work. Great job. Thank you.
Thank you.
Great. We had one other.
Yeah, Steve, can I actually, Andrew Trout, I think, left the room, but he just got an R01 fund, and one of the main goals were actually to establish EPFTs and healthy controls with MRPFTs and healthy controls, and then compare it with disease, because we always ask what's the gold standard. It's now time to really establish gold standards for those. The moderator can choose who can ask a question.
Go for it, and then we have Temel after you.
Take a microphone.
I'm asking everyone, the experts, I'm glad Darwin is here. So why don't we stimulate the SNI in any of these tests? Is there like a good reason not to develop the technique?
The enzymes are from the acinar cells.
So why isn't it being used? Yes.
So while Darwin is walking to his microphone, the secretin stimulates also the acinar cells, not just the ductal cells.
No,
No,
it
it
does
does.
not. It does not. Secretin does not. It may stimulate some it does not. So no, but we have done a CCK EPFT, and we've done a secretin EPFT, and we've done a combined secretin plus CCK EPFT. We published all that data. And one of the falsehoods here is that you can do normals. You can do people. This is a harmless test. And we have an NIH grant years ago, R21, and we looked at normal people off the street. We did an upper endoscopy, and we collected juice for an hour, and no one had any problems. It's a safe test. It's an endoscopy. It's a very safe test. You can do this in children. Now, children get anesthesia, so the pediatrician will need to help us with that, but normal values can be done. we can do this in normal, healthy people. And we publish our data, but it needs to be done in kids.
Yeah, so for enzyme activity level measurement, this is a kinetic test. It measures enzyme activities, which is what you have showed. There are studies that actually randomized children in the 1990s from Indiana University, use secretin arm alone, CCK arm alone, combined, and produced similar results when it comes to the enzyme activities. And that's what I meant by secretin could stimulate SNR cells. It's not physiologically how secretin works. Secretin stimulates bicarb and water secretion from the ducts. But because you do that, the SNR cells do secrete enzymes into that duodenal fluid. I mean, clinically, this test was done. Right. And I'm saying for this test, because EPFTs could be different tests. You could measure bicarb alone. You could measure enzyme concentration. You could measure enzyme activities. And she really is doing a combined test of all of them.
Yeah, that's one of the reasons we want to compare all those modalities all together. And so collect all those data at a similar or like within majority actually within 6 months with each other. And so hopefully it's comparable. Yes.
Thank you, Tim Atrocus from Indiana. I'm a radiologist. I want to say a few words about the secretin enhanced MRCP, specifically duodenal volume that is measured by the MRCP. In my opinion, does not reflect the pancreatic function whatsoever. It only reflects the amount of pancreatic fluid excretion, but it does not detect the pancreatic enzymes, bicarbonate whatsoever. That's number one. Number two, we only image for about 10 minutes. 10 minutes. So this is a very short period of time. Think about two horses coming off the gates. One of them is old, one of them is young. They're all gonna run the same fast rate first 10 minutes, but one of them is gonna fall off, which is gonna be the old horse, but we do not image that with secretin enhanced MRCP because we cannot wait 45 minutes in the MR scanner.
Mm-hmm. Yeah. Yeah, so for the so for first question, so the volume and so from our the data just showing here, like the first several the figures are trying to show, and we do see for patients with the decreased pancreatic enzymes, they do show decreased pancreatic fluid secretion, and then that is also same thing for bicarb as well. So there is a correlation. So even without probably fluid, is just a fluid, but we do see the trend that decreased bicarb, decreased enzyme activity associated with the decreased volume.
Great, thank you.
Yeah, so that is just like data, but it's a small, like a single center, 53 patients. And so we probably need more data really just to enhance the power, but that's just from this pilot 53 patients. We do observe that significant correlation. Yeah.
Great, thanks so much.
Okay, thank you.
Thank you, everyone, for a great set of speakers today. And we still have an hour left. We have a poster session, so please don't leave yet. Please take